Firzah Abdul Aziz from Department of Family Medicine, Fakulti of Medicine, Universiti Kebangsaan Malaysia Medical Center. She graduated from University of Malaya in 1992 and then continued her postgraduate study in family medicine in UKM and graduated in 2003. She then pursued her PhD in United Nations University International Institute for Global Health and graduated in 2015. This is in line with her interest in long-term stroke care and community and economic evaluation and healthcare system research. She has published numerous publications in her specialty, and also she received a UKM Incentive Award for publication in 2020. She also received a Scientific Merit Award from Australasian Stroke Society Annual Scientific Congress in 2011. Currently, she is the Vice President of Malaysian Health Economics and the Professional Society of Health Economic and Outcome Research. So I would like to invite Prof. Dr. Aznida to deliver her lecture titled Patient Safety. The floor is yours, Prof.
Thank you very much, Prof. Firzah. First of all, thank you for inviting me, and I'm sorry about you're going to have to look at the bare walls in my office because there's something wrong with my computer this morning. It just won't pick up the virtual background. But this is my office. I'm in the preclinical block. Okay, I'd like to start this morning session. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Thank you, Prof. Firzah, for the kind introduction. My session today is to introduce or revisit the issue of patient safety, and hopefully to share some stories which some of you might recall to be familiar in your previous workplace, but it is also to be used as an learning experience as you approach your training to become specialists and to be points of persons of reference in your future career. So before I start, I'd like to share with you to acknowledge Dr. Siti Mariam Bujang, who is also a team member for the Training Against Medical Errors for the Faculty of Medicine, UKM. Right. At the end of this session, it is hoped that the audience will be orientated to the discipline of patient safety, and also be reminded that we always in constant practice to reduce the incidence and impact of adverse events and maximize recovery for our patients who visit us for their medical problems. So let's start with the definition of patient safety. Patient safety is actually the absence of preventable harm to a patient during the process of care, and the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. Okay, and patient safety is an issue that is seen in all the countries that have healthcare services, organized healthcare services. And a number of literature have shown that some of the common denominators where patient safety has been compromised have resulted in either permanent injury or even increased length of stay in the hospitals or healthcare facility, and at the extreme end, you have patients succumbing due to the errors that have occurred during their care. Some of the examples that have been well documented in literature would probably be familiar to some of us, where there have been lapses in prescription, where you might have written a prescription for the wrong person with the same name or or in your moment of hurry during clinic, you have actually signed, entered the prescription on another patient's panel instead of the patient that you were currently seeing. And the other error that we quite often see is the administering of multiple drugs or polypharmacy without paying attention to the potential adverse drug-drug interactions or even adverse drug reactions which can cause harm to the patient. Okay, and in the era of IT and electronic health records, there is also potential for misuse of technology where patients can be harmed by poor communication between different healthcare providers or even delays in receiving treatment. As a primary care physician, we tend to get very poorly written referral letters, for example, for transfer care or follow-up care. And the only jarring thing, or that's something that's clearly written, would be the last sentence saying, please do the needful. And then we all embark into a Sherlock Holmes kind of activity, trying to track back all the information that should have been forthcoming in the first place. Okay, so what should we know? What should we be aware when we consider patient safety? We need to know that harm can be caused by healthcare errors and system failures. We need to be able to learn from mistakes by others, particularly huge ones that have occurred in industries, right, that have some effect on healthcare professionals. History of patient safety will orientate you to how patient safety has evolved in the last several decades. And a most interesting aspect would be to identify what sort of cultural practices in your organization that have led to or promoted errors or even prevention of errors in the organization. We will briefly use some examples to discuss system failures, violations, and errors. And at the end, we will show you a model of patient safety that should exist or that we should be aware of in the place where we practice. Now, what is required for us as clinicians? We need to be aware that patient safety is the most important factor when we are dispensing our clinical and professional activities. And the ability to care extends to the ability to recognize the role of patient safety when we deliver this our clinical management. Now, what is the effect of healthcare errors and system failures on the patient? Is discussed, is usually mentioned in the classified in the extent of the adverse events, and the adverse events are mainly categorized by level of seriousness. The extreme end would be the patient succumbing to the death, succumbing because of the errors, and or even worse would be prolonged disability, which results in reduced quality of life. And of course, when there are errors, and there will be significant economic and human costs associated with adverse events. Okay, what can we learn about error and system failure from other industries? Large-scale technological disasters, for example, contaminated saline solutions for contact lens wearers have severely affected patient safety, safety of patients using contact lenses, for example, an increase in corneal ulcerations as a result of this error from the industry. And then in most investigative reports from the industries, the common denominator would be due to the poor safety culture practices. Now, in order to explain the mitigating measures on how we can prevent the spread of complications, we need to be aware of the Swiss cheese model, right? Just to orientate, it's not common for Malaysians to eat Swiss cheese, so I thought I'd show you what the Swiss cheese actually look like. It's that cheese that you see in the Tom and Jerry cartoons, the one with the holes, okay? So the holes actually represent loopholes or areas where the mitigating factors, the solid part, which are the solid part of the cheese, although have been in place, have escaped for some unknown reason, have been missed, and slipping through these holes, these have resulted in huge losses in terms of the patient in this case. So a good example is to talk about the elephant in the room, which is COVID-19. And this is a Swiss cheese model and that have been applied in terms of the virus pandemic defense. Now, we know that in general, we have personal responsibilities. It's up to the individual to protect themselves from the pandemic, but we also have the we also, as healthcare professionals, we contribute to the shared responsibilities for the community. So the mitigating factors are factors that have been in place is the public health advisory, where we are supposed to follow the SOPs, physical distancing, putting on your mask, practicing good hand hygiene, cough etiquette, and avoid touching your face. And to use their discretion when going to a public place. If it's crowded, please limit your time if you really cannot avoid going into that area. But on the other hand, you will find people who have forgotten, or because of pandemic fatigue, have stopped doing all of this, and hence then you will get people succumbing to COVID, although these measures are followed or taken up by the majority of the population. And in the healthcare workers, healthcare providers' responsibilities, we have mitigating measures like testing, giving fast results, checking on the ventilation and air filtration, and so on and so forth, including the vaccines. Another example that is also commonly seen where patient safety is compromised is from this study, why do interns make prescribing errors? As you know, internship, I think the equivalent in the local healthcare context is the housemanship period, where they are still under training and they are still they're only partially registered, and they found that there are a lot of mitigating factors that have failed to protect the patients from errors conducted by the junior doctors. Okay, so and this particularly, I think this study was based on some of the in the system where there were still written prescriptions in place, and handwriting, and also again using writing out the prescription for the wrong patient. And henceforth, after this study, there was recommendation that perhaps even so, if there was an electronic healthcare system flagging flagging out the errors or feedback to the system to actually prevent the errors from taking place, should be emphasized or should be considered when you're looking to buy an electronic health system. Right. Now we come to the interesting part. Now, history of patient safety and the origins of the blame culture. So, blame culture, I will briefly give examples on some of the blame culture and what sort of environments where these conditions exist. And then we'll see some interesting stories of person approach and systems approach in the blame culture. Right. Now, the blame culture. The blame culture is a work environment. Blame culture is strong in an organization where silence is the predominant response in healthcare organizations to performance problems. People keep quiet. People fear to talk because particularly so when the problem or sometimes they like to label people by calling them troublemaker. And the troublemaker is somebody from a high status professional group. Now, the set of or norms and attitudes in an organization is nicely summarized as why rock the boat when there are no waves in sight. Okay, so people are unwilling to take risks or accept the responsibility for mistakes because of fear of criticism or management admonishment. They don't want their personality or their standing in the organization to be compromised, although the majority of the people, the hardworking people, the people who don't indulge in office politics, are always feeling demoralized why somebody with the ego so big gets away with literally murder in some situations. So everybody keeps quiet, and the loudest voice of the day will continue to bully others in that organization. Okay, so it's been well documented, and and it's not just limited to the local healthcare setting, it's global. All right. And then again, the ideal as an opposite to the blame culture, working in an environment with just cultural practices is a very it's a happy place. It's a happy place for many people aspire to be in this sort of organization where technically if you do right, then you will be justly rewarded. But if you do wrong, then you will have to be responsible for the error, but we move on. We move on from there, and it is taken as a learning lesson, a learning curve, provided the error that has been made is not huge or is not detrimental or is repeated, then it is should be looked at positively, because for every one single error that a person has made, they probably must have done 9,999 things correct at the first time. So the just culture is an environment supportive of open dialogue to facilitate safer practices. And supportive work unit members believe that they can ask questions regarding existing practices, express concern or dissent, and admit mistakes without suffering ridicule or punishment. Asking questions but then again, you must beware, but there's some people who just love to ask questions as a show of how much knowledge that they have. But in a person who is genuine in their interest in asking questions would technically be a positive person, offering to share enhancement of current practices or doing things in a different way, which will help move the organization forward. So an organization's ability to identify, report, and investigate incidents and to take corrective actions that improve patient care system and reduce the risk of recurrence is technically a just culture environment and a non-toxic environment for people to work in. The only setback would be that if you try, if you inherit if you come on as a newbie, inheriting an organization that had problems inherent before you came in, and then there were problems with the organizational systems, it can be difficult to make the change, but slowly and surely, and if changes can be made. And the following up on incident report is a huge setback for some organizations, because if there was if there was an incident report, then it must be adequately addressed. And how is it addressed? You will have to have a panel which investigates and recommends the necessary changes or enhancements to be made. And the only thing that a lot of something that is mentioned in the literature is a just culture can be overburdened in terms of getting the correct people to actually sit on the review boards and investigative panels, because this can be a cost burden to the organization. Okay, so and then we talk about just a historical perspective on the patient safety and quality of care. In the late 80s and up to the early 2000s, the capacity building was, I would say, evolved rather slowly, because and there was incremental progress that took place, and were very focused, first of all, starting with awareness about patient safety. Historically, I would guess that if you were practicing in the early 80s, you recall, or you had family or relatives who were practicing in the early 80s, where the doctor's word was law, and the doctor would, nobody would question the doctor at all for any decisions, so never questioned the diagnosis at that time, and no such thing as asking for a second opinion. And over the years, you see education, collaborative improvement, redesign, getting people more aware of practices on patient safety, finally culminated in some action going full scale and changing mainstream practices worldwide. Okay. Okay, another story, person approach. This is a story which illustrates how somebody had to take the fall or the rap for what seemingly was the person just responding in his or her role as a medical officer. Now, the story starts with a medical officer being called to do a bedside group cross match for a patient in ICU who was had gone into severe hemolysis. And just so happened that when the medical officer went to the ICU, entered the ICU with the blood bank technician, they encountered the patient's daughter, who is a teacher, who was seated next to her mom in the ICU. So the medical officer proceeded to introduce the team and said that they were there to do the bedside group cross match. And the daughter asked, why are you taking more blood from my mother? The usual, why are you taking more blood from my mother when she's clearly bleeding from everywhere? Why do you need to take more blood? So to explain why he or she had to take the blood, the patient said, we need to confirm, the doctor said, we need to confirm your mother's blood group because we need to be sure that we are giving her the correct blood. And this started the ball rolling for what a chain of events. In short, the patient finally succumbed because of the wrong blood group was given, was transfused in the patient. And this happened, and why this, the medical officer who was on duty, unfortunately, or rather unfortunately, was the person who discovered that there were different requests, different blood group requests for the same patient with the same name, the same RN, and had discussed with the specialist on call on how to proceed, notified, and to seek advice on how to proceed. So in the end, the patient's family decided to sue the hospital for negligence. And there was an inquiry that took place, and it was found out that the error had occurred at the point of admission of the patient, where the house officer was helped by her kind friend to help take the blood, but unfortunately took the blood simultaneously for 3 patients, and was not the house officer who labeled the blood tubes. So in the process of this inquiry, luckily for the 2 other patients, no blood transfusion was required. So the other 2 were saved, but they were regrouped and re-cross-matched to confirm their blood groups. And in the end, the house officer was absolved from the inquiry. The MO was transferred to another department, and after the hospital inquiry, because there was no, in terms of wanting to add on what was the remedial measures as resulting from this inquiry, somebody had to be the fall guy. Now, in systems approach, remember earlier with the advent of advancement in technology, we have electronic health records, but electronic health records are being machines, we thought that, you know, they would be foolproof, lesser errors can occur, with lesser impact on patient safety. But in this study, it was found that the errors actually occurred in the pharmacy systems, medication related, followed by the diagnostic labs and also radiology. Now, errors can happen. So the vigilance or the balance and check mechanisms have to be in place, and the human input and should not be overlooked. Although you may have the most recent device that guarantees to be 99.99% safe, but the 0.1% from the clinicians and the healthcare personnel does matter. Okay, so the difference between system failures, violations, and errors, another story, the Harold Shipman story. Harold Shipman was GP in the 70s in the NHS in UK. He was famous for killing close to almost 100 over patients in his practice from overprescribing pain relief, diamorphine. Now, to demonstrate the professional accountability in this story is that Harold actually escaped detection by the authorities for many years, I think almost 2 decades, until a GP in a neighboring district actually noticed that there was a high number of deaths in among the patients in Harold's practice, on the average of 1 per week. And the story is quite long. If you can Google it, you will also find that Harold was also into altering wills and directives from patients who were considered terminally ill. Now, the professional accountability was noticed by the neighboring GP, and in terms of violations, there was this was Harold deliberately prescribing extra doses of diamorphine and also non-indicated diamorphines on patients who clearly do not need such strong painkillers. Okay. So types of violations can be, and there are many, and I think we can always look that up. Now, one of the other things that I mentioned earlier was perhaps the violation or deviation without intending to do much harm. This was a study that was presented recently in a conference by the World Family Doctor Association, where top reasons for antibiotic prescription without indication. These were top 10 reasons given by clinicians, primary care doctors, and some of them like the top reason would be patients demanding for antibiotics. And similarly, locally, you will find such situations because the report on the National Health and Mobility Survey on communicable disease has just been out, it's just been released. Malaysians too have poorly understood the difference between what's a virus and a bacteria, and how asking for how antibiotics do not work on viral illnesses. Okay, so interestingly, both doctors and also the general public need to improve on their awareness on the antibiotic resistance as a result from non-safe reasons for wanting to prescribe. Now, the model of patient safety was described by Emmanuel in 2008. It has 4 components, and first of all, it's the people who work in healthcare, that's us, the healthcare professionals, and then there's the patients who receive healthcare and have a stake in its availability. And then we have the infrastructure, the healthcare delivery process, and then the methods for feedback and continuous improvement. So this is a model that should be in place in all organizations. It's just the extent of whether the management would like to take up on it, how far they would implement, and how efficient the system would be running in any organization. You have the recipients of care, and you have the systems for therapeutic action. And this, remember the Swiss cheese model, the mitigation barriers to prevent errors, and then you have the workforce, okay, and continuous quality improvement, or sometimes known as audits, should be in place regularly, right? Now, I'd just like to remind everyone that we are very well aware of the clinicians' expertise in managing patients, because we have the knowledge on disease diagnosis, the etiology, treatment options, and the outcome probabilities based on what we read in the journals and how we update ourselves. But many of us clinicians tend to forget that patients too are actually experts, because they are the ones who have the first-hand experience of the illness, and they come with social circumstances that may or may not contribute to their current state of health. And they also, how they respond to risk, their coping mechanisms, for each patient, for each person, in fact, is actually different. And patients all come with values and personal preferences, and we need to understand that they too have a right. But in the end, when it comes to counseling patients, we need to be able to present the topic to them with enough information for them to safely make the decision in terms of treatment options. Okay, so the application of patient safety thinking in all healthcare activities encompasses developing a relationship with your patient, understanding the multiple factors involved in failures, avoid blaming when an error occurs, practice evidence-based care. And that's why we're all in this program to push you all to become specialists who will make evidence-based care your priority and to upgrade your skills. Maintain continuity of care for patients, be aware of the importance of self-care, and most of all, act ethically every day. So as you prepare to go into your program, and also when you prepare to go into a healthcare organization as a specialist when you graduate, you need to recognize the role of patient safety and ask questions about other parts of the health system. You have to know what your environment is like and ask for information about the hospital or clinic processes that are in place to identify adverse events. And just to highlight that every 17th September every year, the World Health Assembly has identified it as the Patient Safety Day. And the aim of the World Health Organization is to establish synergies between health worker safety and patient safety policies and strategies. So we just actually missed the World Patient Safety Day, and for 2020 and 2021, the theme will be health worker safety, a priority for patient safety, meaning that for patient safety to exist, the health workers must be safe too. And they have 5 goals. They've identified 5 goals, and they have recommendations, so all available on the WHO website. But what I would like to emphasize would be this one, where the zero tolerance of violence against healthcare workers. On and off, you do find angry patients in your clinics or angry patients in the wards, particularly and sometimes rude patients that you may encounter in when you're working. You must be aware that there are also rules that protect the healthcare workers from such patients, and be aware that you must also be aware of the safety routes in your clinic and the safety measures that should be in place in wherever you practice. All right. And that is the end of my presentation. And I hope you've been enlightened in the last 1 hour. Thank you.
Thank you very much, Prof. Aznida, for a very interesting topics. Yeah, it's very close to our heart as a clinicians. If you have any questions, please type in the Q&A box. Yeah, I have one question to Prof. Aznida regarding the zero tolerance towards violence towards healthcare workers. Okay, this is quite common in my field, basically because in ICU, you know, they are frustrated, and okay, sometimes we do face this quite frequently, I would say. So what is your advice for us to if we face this kind of family members, you know, they are actually, we do understand up to a certain extent they are grieving, they are sad, you know, there is a lot of emotional disturbance in them. But do we have to up to the extent to make a police report maybe?
That would depend on the situation, on how severe the threat is. I'm not, I've also had worked as a surgical MO many many years ago. Yes, I do understand you may get the violent patient or the violent guardian or caregiver, but the main I think the root of this actually stems from the miscommunication, which probably has occurred at several levels before the patient has entered the OT. And just because the anesthetist happens to be the end of the line, and they're the most quiet ones in the group of healthcare providers, I've never met a loud speaking anesthetist by nature, right? Very it's kind of sad because then actually the anger is misdirected. In terms of reporting, I think that there is a set of protocol. What I was alluding to when I was talking was actually in clinic, but I think there is a set of rules, and I know when you go to the counter, the registration counter, they always have these little posters that says that we have zero tolerance to rude clients, right? We treat you kindly, we are polite to you, and if there is no just cause, then we will not tolerate people shouting and turning violent. But having said that, I too have been in situations where patients have been violent, and it's not the patient, it's the patient relatives who have come in. And the worst case scenario was the patients that were violent in my clinic were actually a couple who were both police officers. So in the end, how that was solved, I did not have an escape route at that time. The clinic was designed in a way that there was no windows, there's only one entry. So that's why I mentioned that wherever you're working, the first thing when you go and work in a new environment, you need to know where the escape routes are for your protection and for your own safety. Lucky for me, one of the thing, I had very good staff and a very good security guard who came to my help. And these were the days without handphones, yeah. And even then, after that, my good colleagues in psychiatry department at that time actually took over the violent husband and wife. But after that, I never saw them again because I don't know what happened to them. But resulting from that incident, it prompted the organization to actually look at the safety exits for the clinic. And now at our new clinic, our primary care clinic, which is outside the hospital in Bandar Permaisuri, we do have safety exit routes. The staff call it lorong tikus. So the back lane. So that's important for a point to take note. And I think the protocol for the violent stuff too, I think there is a guide. There is a guide that actually includes whether you need to make a police report or not. But I think in the OTs, I think the OT managers would be well aware of the protocols on how to deal with this sort of incidences. I hope that helps.
Yeah, it does help. Maybe I think it's a high time for all of us to have a look at this method, because with the newer how to say a Google well-formed community, so sometimes it's very hard for us also to manage. Do we try our best, but sometimes things does happen. There is one question for you, Prof,
Okay.
from Dr. Rujila. So in the event that a patient is unable to afford their medical fees but in dire need of medical attention, is there a role of medical personnel involved to ensure that the patient receive proper care despite not being able to afford it?
Okay. First and foremost, I'm a primary care physician. I've had patients who, majority of my patients are from the B40 group, okay? There have been instances where patients have come to me and they say that they don't have enough money to come for follow-up and they're really poor, and basically we check the background and it's a legit kind of story. So I think we all need to be aware that the payment for services, I think many of us are unaware because we are government servants and we are on GL or you know, government employees. We don't see money changing hands when we need medical treatment. But for patients who are under B14, those not subscribed to B40 or My Salam, then they will have to pay. What clinicians can do is that it's for me, if I find that they have access to the nearest government clinic. If they can't afford UKM or university fees, then I would recommend that they go there. But on the other hand, there have been instances where the patient, this is what, I'll let you in on a secret. This is what most primary care doctors do actually. Sometimes they do end up paying for the patient's prescription because they know they see patients from womb till tomb, so they have a fairly good understanding of the patient's social circumstances. That's what most of my colleagues do actually. But the other thing that I always remind my students is that you try and limit the number of visits and try to cut costs wherever possible. Because some patients, they will tell you, okay, I'll go to clinic X, and the next month you see them back again, although they've told you that they can't really afford the treatment, right? And then when you ask them why, then they say, we come back, it's not because of the clinic, we come back because of the service that you provide. So that is one of the reasons, but I am sure that there are many in the audience who have been known to actually help pay for certain things that they feel